Hello, good afternoon, everyone. And this session is one of a highlight session in highlight time in TCTAP 2024. It's about the story about the vulnerable plaque from diagnosis and treatment. As shown today morning, Gary Min's lecture, and this time is a very good discussion time about prevent trial and vulnerable plaque. I'm D.W. Park from Assam Medical Center. I'm co-moderator, and Evelyn Regar, and we invited world-renowned expert in this field, and the panelists, Ziad Ali from US, and Sun Jun Hong, and South Korea, Ik-Kyung from US, and Takashi Kubo in Japan, and Myung Lee in South Korea, Shamir Mehta in Canada, and Yoshinobu Onuma in Ireland, and Dr. Yokoi, and we come together as all world-renowned expert. And I'm gonna turn the baton to Dr. Evelyn in the first section.
Good afternoon, everybody. It's my distinct pleasure to call the first speaker, Dr. Akiko Maehara. What is a vulnerable plaque? Insights from invasive intravascular imaging.
Thank you. So we can define the vulnerable plaque, which causes thrombotic event or rapid lesion progression. To understand what is a vulnerable plaque, we learn a lot from the pathologist. What they tell us is thrombotic lesion is about 70% is plaque rupture, 30% is plaque erosion, 5% is calcified nodule. How it looks like underlying plaque is very different compared to the different pathophysiology. If that is plaque rupture, big necrotic core, syncap, and rupture of the syncap, that's causing the thrombotic event. On the other hand, if that is plaque erosion, limited amount of the lipid and thick cap, and because of the deficiency of the endothelium causing the thrombotic event. If that is calcified nodule, underlying plaque is very, very severe calcium. So they are very different. And if you look into those underlying morphology in the living patient, actually answer is quite consistent. Everybody say plaque rupture is about 70% and plaque erosion is about 30%. And then if you look into the underlying plaque, TICFR is most frequent in the plaque rupture, and that's very rare in the plaque erosion. So when we look into the so-called vulnerable plaque, we have the different aspect. What kind of plaque morphology, pathophysiology are we looking for? So this is the most famous patient in the prospect 2. After the treatment of the culprit lesion dystrophy and proximal lesion was imaged, you see the large plaque and small lumen and large lipidic plaque. And the patient coming back about 3 years later, you see the big progression of the lesion. There is a many prospective multi-center study to show the association between the so-called vulnerable plaque and the future event. Using the near-IVAS prospect 2 and the LRP study, the patient who had lipid-rich plaque had almost 2-3 times event compared to without. By OCT, combined FFR or PECTAS observation study, they show quite consistent data. If the patient having the TICFR, they have more event compared to without. And if you look into only the much vessel imaging study and lesion level data, the answer is very consistent. Plaque burden is always significant and minimum lumen area. But when we look into the lipid-rich plaque, looks like OCT-defined TICFR having more higher hazard ratio compared to the near-IVAS-defined TICFR. This is a meta-analysis and consistent, showing the TICFR or lipid-rich plaque causing the future event. Those are the major factors which you already know to define the vulnerable plaque. Lipid-rich plaque, syncap fibrillary. What else? And intraplaque hemorrhage was shown a long time ago by the pathologist. This is the most important, one of the important factors to associate the atherosclerosis progression. And this is the OCT picture for the intraplaque hemorrhage. And this is all case report. It's not very consistent, but you see the intraplaque hemorrhage and associated OCT finding is low intensity area without significant attenuation. And we look into this phenomenon, and this is a large lipidic plaque, but adjacent, you see the so-called intraplaque hemorrhage, low-intensity area without attenuation with cholesterol crystal. And because of the pathologists tell us, if you have the intraplaque hemorrhage, most likely the cholesterol crystal together with. And then based on this, we define intraplaque hemorrhage and cholesterol crystal. We show that findings on top of the TICFR to be associated with a future event. However, it's a little bit concerned because there is no clear evidence in terms of the validation compared to the pathology. And this is probably the one promising imaging, so-called near-infrared autofluorescence. When we use, we see more fluorescence in the sum of the necrotic core. And what it is, they show insoluble lipid protein formed under oxidative stress, meaning more oxidative stress lipid is corresponding to the near-infrared autofluorescence positive segment. And this is the first in my picture. You see the nearest IBUS autofluorescence, nearest OCT autofluorescence, and up to here, you start seeing the high signal that's probably indicating the oxidative lipid or intraplaque hemorrhage. So those probably in the near future could be important to predict or define as a part of the vulnerable plaque. On the other hand, plaque erosion is very different. And there is two important aspects which I think there is two separate people showing the almost consistent data. If we look into the plaque erosion, at the site, higher endothelial shear stress, and also the gradient of the endothelial shear stress is higher compared to adjacent segment or compared to the control group, which having the same MLA and reference lumen area. So those kind of focal high shear stress could be important to predict future plaque erosion event. And the other thing is I do think the spasm. This is reported from this country, South Korea, and Dr. Shin, they show almost 10 years ago, they including only the spasm patient and look into the OCT in that segment, and they show 26% of the spasm lesion is actually plaque erosion, defined as no plaque rupture and thrombus. Also, they show 61% is actually lumen irregularity that may indicate the deficiency of the endothelium. So those probably, compared to the plaque rupture, quite different, but local shear stress or spasm could be important. And this is a different paper from Japan. They including 51 vessels with 39 patients with all spasm, and then they show quite consistent data. You see the layered plaque and low intensity area, that's probably indicating organized plaque erosion. So probably those patient characteristics could be important. And in terms of the calcified node, that's a totally different aspect. To answer the question, we include 372 calcified lesions in 350 patients, which having the 2 times OCT. Our question was, calcified plaque is causing the new development of the calcified nodule. And answer was yes, and we found 7% of the calcified plaque in the future causing the calcified nodule. So this is the baseline OCT, you see the calcified plaque. At the follow-up, you see the radiolucent, and by OCT, we see the new development of the calcified nodule. At the event, you see the radiolucent opacity that's indicating the calcified nodule. And what is a predictor of the calcified nodule development is large calcium and also the calcium with attenuation, indicating the immature calcium and high hinge motion movement. And if the new calcified nodule appear, they have the poor outcome compared to without. So I do think when we define the vulnerable plaque, we have to define different way based on the different pathophysiology. So if we are talking the vulnerable plaque to predict the plaque rupture, that should be lipid-rich plaque, think fibrous cap, and probably intraplaque hemorrhage or inflammation is important. But when we look into the plaque erosion, the vulnerable plaque should be more shear stress or coronary spasm. This could probably part of the reason of this phenomenon. And finally, the calcified nodule, the vulnerable plaque causing the calcified nodule is really severely calcified plaque and the hinge motion movement. Thank you.
Thank you. We proceed to the next speaker, Yoshinobu. What is a vulnerable plaque? Insights from non-invasive imaging modalities.
Yeah, thank you, Chairman, for the introduction, Evelyn. My topic is non-invasive imaging. Just to remind you, vulnerable plaque was first invented by Professor Jim Mueller in 1989 as a plaque at increased risk of thrombosis. The search for the precursors of culprit plaque underlying acute cardiac event has been the subject of multiple investigations using different invasive and non-invasive modalities. I think Dr. Maehara already showed that slide, but just to remind you, the underlying plaque is a 60% or 70% plaque rupture, 30% erosion, and 5% calcified nodule. And we want to really looking at the precursor of those plaques in different modality of imaging. CT is suitable for the imaging for the primary prevention population because it is non-invasive and you can really screen the patient who doesn't have a previous cardiac events. If you look at the difference between the modalities, CT has moderate spatial resolution, 0.4 millimeter, depend on the generations, and you can look at the Libet-Rich score, the low attenuation plaque or calcification, the positive remodeling, but it's not really good for the looking at the fibrous cap thickness. For example, it's beyond the resolution of the CT. Typically, the high-risk plaque on CT is either positive remodeling or the low attenuation plaque, low Hansen field unit, napkining sign, which is enhancement of plaque by the contrast of the spotty calcium. There was a couple of the autopsy studies performing the post-mortem CT and compare that with the histology. So this is one of the recent publication in 40 certain cardiac deaths due to the acute coronary syndrome. 75% of the cases, they see the positive remodeling greater than 1.1 in the index, or there was a significant correlation of the presence of napkining sign and intraplaque inflammation or the severe adventitial inflammation and increased vasorum. Also, there's a correlation between the spotty calcium versus on histology, the presence of the punctuate or the fragmented calcification. And also there was a correlation between the enhanced plaque versus the plaque inflammation, and they found that this plaque enhancement is the one of the new sign of the vulnerability of the plaque, which correspond to the histology, which is also correlated with the inflammation of the plaque. There's another post-mortem series, 35 cases. Again, the contrast enhancement on the CT of the plaque is related with the histopathological plaque inflammation and increased vasorum. You see these two cases. There was the enhancement of the plaque by the contrast CT, and that corresponds to the mononuclear inflammatory cells surrounding vasorum or the in the erosion in this case. So the plaque enhancement of multi-phase CT angiography is maybe as a non-invasive marker of the inflammation. What about the clinical data? There was a lot of studies showing the importance of the CT for the prediction of the event. The CT can provide not only the plaque characterization, but also for the provide the FFRCT or the perfusion or even looking at the perivascular fat. And this is a classical study from Japan in 2009 that if you have plaque characteristic of positive remodeling and low attenuation plaque, those patients has a higher event rate of the 22% compared to the 0.49% for the patient without plaque or no positive finding of this positive remodeling or the low attenuation plaque. These were also confirmed with the Scott-Hart study. You see that the patient was classified according to the presence of the adverse plaque, which was the positive remodeling and or the low attenuation plaque. The patient who has this adverse plaque has more event, 3 times more frequent event, which is death or myocardial infarction, compared to the one who doesn't have the adverse plaque. Also, the stenosis is important. It also predicts the future event. But if the patient has both adverse plaque and obstructive plaque, then those patients has a 10 times more frequent event compared to those with the normal coronary arteries. Further I think the Scott Hart trial group also looking at the impact of low attenuation plaque burden on the future myocardial infarction. You can see that the low attenuation plaque burden is the strongest predictor of the myocardial infarction. A patient with low attenuation plaque burden greater than 4% are 5 times more likely to suffer MI compared to those without this low attenuation plaque burden. These are also confirmed in the meta-analysis. If you look at the CT parameters, low attenuation plaque near spectroscopy spotty calcification has an impact on the patient-level major adverse cardiac event. One word for the perivascular fat attenuation index. It is established and published in the Lancet. You can look at the inflammation of the fat around the coronary artery, which is reflecting the inflammation of the coronary artery. And if you have a high perivascular fat attenuation index, then it is an indicator of increased all-cause mortality or the cardiac mortality. This was also confirmed in the other series. Also, the Professor Ko from Korea have shown the result of the Emerald-1 study demonstrating that the adverse hemodynamic characteristic has also the impact on the prediction of acute coronary syndrome. What is the adverse hemodynamic characteristic? It is a FFRCT change in the FFRCT across the region or shear stress and axial plaque stress. By taking into account these adverse hemodynamic characteristics, the significant improvement was observed in terms of the prediction of the acute coronary syndromes. And recently, last year, Emerald-2 study was presented by Professor Ko at TCT. You can see that this time the artificial intelligence-enabled quantitative coronary plaque and hemodynamic analysis was performed, and that significantly improved the prediction of the future acute coronary syndrome. And the new prediction model also provides time-dependent ACS event probability. So these are the summary of the studies of the CTA for the prediction of future event. You can see that positive predictive value of the event rate with various duration of the observation ranging from the 4.1 to 22%, but also the perivascular fat attenuation and AI-based plaque and hemodynamic characteristics will further improve this future event prediction. The next step is probably the photon counting. This is a new technology on CT, and it's a quantum leap. You can really see the significant improvement of the quality of the images. The maximum resolution is 110 micron. You can see the calcium or the stent without significant blooming artifact. And recently, the group of the Goncalves showed that using this CT, the photon counting CT on the carotid artery, that they could somewhat differentiate the hemorrhage and the thrombus from the other type of the tissues, so that can also potentially improve the prediction of the CT and characterizing the vulnerable plaque. Now, as a conclusion, autopsy studies with postmortem CTA in patients with sudden death suggested that plaque enhancement is a non-invasive marker of inflammation. High-risk plaque characteristic on OCT include low attenuation plaque, positive remodeling, napkining sign, and spotty calcification. LAP is a strong predictor for the future myocardial infarction. Perivascular fat and the use of the AI for the quantification of the plaque or the hemodynamics could further improve the risk prediction. Newer generation of CT, such as photon counting, might further improve the spatial resolution and may enable to further characterize the individual feature of the vulnerable plaque, such as hemorrhage and thrombus. Thank you for attention.
Thank you for covering so much ground for us. And we take it even further with Dr. Ik-Kyung. He will give us insights from CT and an OCT study to detect vulnerable plaque.
Thank you very much for the invitation. I was asked to give a talk on covering both invasive and non-invasive. So this is my disclosure. So the aim of our research is to identify vulnerable plaques in the coronary tree and treat them with local or segmental therapy. This is what I said at the interview with the Wall Street Journal 21 years ago. That was shortly after we performed the first OCT procedure in a living patient. So that was the goal. Identify vulnerable plaque and treat it. Human biology is not that simple. Over the past 20 years, we have learned so much. Is that my initial idea 20 years ago was almost obsolete. So with Dr. Minami, we prepared a chapter for Dr. Brown about heart disease, which will be published shortly. So in that chapter, our definition of vulnerable plaque is a plaque that is prone to disruption, either through rupture or erosion, leading to acute occlusive thrombosis, not silent thrombosis, occlusive thrombosis, which will result in either myocardial infarction or sudden cardiac death. So it has to be occlusive thrombus. So the definition of vulnerable plaque used in recent clinical trials were a little bit different. And they used a definition of plaque that is prone to rapid progression, leading to progressive angina, requiring revascularization, and small number of patients, MI, and cardiac death. And as you are all aware of, the endpoint that drove the whole trials is not MI, it's not acute MI, it is progressive angina. So what we are talking about is either plaque phenotype or plaque burden. So I went back and looked at the different sources to find out what's the definition of vulnerable. Vulnerable comes from Latin word wound, and in Britannica, is easily hurt or harmed, leading to irreversible damage, not just angina on exertion. It has to cause irreversible myocardial damage. So I'm going to just briefly summarize these 4 facts, all related to plaque phenotype, and then I will cover plaque burden later on. So the theme of our research group over the past 20 years is atherosclerosis is panvascular process. It's not local process. It's a panvascular involving all 3 coronary arteries with possibly local manifestation. So this is a study that we published in ATVB with Rocco Vergallo. So there is a continuous plaque rupture, erosion, and healing, rupture, erosion, healing. So evidence of plaque rupture you can often see on OCT. So Rocco compared the plaque characteristics between patients with the evidence of plaque rupture in the past and those without. And as you see here, the yellow-green bar represent patients with non-culprit lesion rupture, and those patients had higher level of vascular instability, vulnerability, lipid-rich plaque, TICVA, microvessels, macrophagia, and all those. So the fact that patient had that silent myocardial rupture puts the patient in high-risk category with high level of vascular inflammation. So Makoto Araki recently looked at spatial distribution of plaque phenotype, all different types of phenotype. I want you to draw attention to the bottom one. Red is a TICVA. So TICVA is not only in the proximal segment, it's all over the place. Especially in the RCA, it is found everywhere, including the very distal segment. So the very simple concept of identifying plaque in the proximal segment and treat it, that's not right. So as Dr. Onuma said, we also look at the panvascular inflammation using non-invasive method, PCAT, is pericoronary adipose tissue attenuation. The yellow represents low level of inflammation, red, high level of inflammation. So patient presented with chronic coronary syndrome, as you see here, pretty much everywhere is yellow. Panvascular, low level of inflammation, whereas patient presented with ACS, everywhere is red. It's not one spot red, it's a panvascular inflammation. So plaque phenotype changes, this is a work from Dr. Mintz and Kubo. So 75% of VH TICVA will stabilize, will become stable. So plaque phenotype changes dynamically over time. And Dr. Kinoshita recently published. So we used OCT as a gold standard, try to find out whether CT, 4 features of high-risk plaque on CT, has any correlation. Indeed, all those 4 features that Dr. Onuma mentioned, positive remodeling, low attenuation plaque, napkin ring, and spotty calcium, they were all associated with high level of vascular inflammation identified by OCT, particularly positive remodeling. So subclinical plaque disruption healing, it has been known for a long time in pathology. 73% of people who died of cardiac etiology, when they look at the coronary plaques, they had evidence of previous plaque disruption. Some people have multiple episodes of plaque disruption. So we look at the prevalence of healed plaque in living patients. So in stable angina, you can see evidence of plaque disruption previous in more than 50%, in ACS more than 25%. So it's a balance between local systemic thrombogenicity and defensive antithrombotic mechanism. But regardless, there's a continuous plaque disruption and healing. That's the main mechanism of plaque progression. So finally, as you know, plaque erosion is responsible for up to 40% of ACS. As far as I know, there is no known precursor for plaque erosion. So even though you had a perfect method to identify precursor of plaque rupture, you will miss 40%. So briefly, vulnerable plaque clinical research, obviously 2 landmark studies, prospect and prevent. As you see here, what really drove the whole study is recurrent angina, not cardiac death, not MI. So Dr. Stone identified 3 predictors: plaque burden more than 70%, MLA 4. So these are related to plaque burden, not plaque phenotype. And third one is VH-TICFA. It is plaque phenotype. However, the definition of VH-TICFA is you have to have plaque burden of more than 40% and invisible fibrous cap. So again, even VH-TICFA plaque burden is an important component. So my take-home message from prospect is positive predictive value is very low. The risk of MI of VH-TICFA was 1%. And more importantly, actually, 1/2 of patients with MACE had no high-risk plaque. And plaque burden, as opposed to plaque phenotype, is an important factor for development of recurrent ischemic event, not cardiac death, not MI. So, sort of Bostonian word, it's no-brainer. You don't need to brain. When you start with low plaque burden, decrease in luminal area of 1.5 will lead to a little bit narrowing of lumen. That's a mechanism of plaque progression, but not the mechanism of acute coronary syndrome. The residual lumen would be still decent. When you start with high plaque burden, the similar degree of plaque progression will lead to a critical narrowing, causing progressive angina. So this slide, Dr. Park kindly provided, significant reduction in composite endpoint, but again, it was mainly driven by ischemia, not MI, not cardiac death. So the conclusion that I have is detection of vulnerable plaque helps to risk stratify patients. So in other words, you do whatever modality you want to use and identify either CT, one of the 4 features, or TICFA, whatever. It doesn't mean that particular plaque will lead to occlusive thrombosis. That just puts the patient in a high-risk category for future event because that represents panvascular inflammation. And plaque burden is a strong predictor for future revascularization. Preventive PCI reduces revascularization, MI, and cardiac death during 7-year follow-up and prevent trial. I think vulnerable plaque is probably a misnomer. High-risk plaque rather than vulnerable plaque may be more appropriate terminology. Thank you.
Okay, So I'm going to discuss, and this is very important time. So I'm going to, so our Prevent trial in the Lancet journal, and the 5 reviewer is reviewed our Lancet very thoroughly, and the 4 reviewer is generally positive, 1 reviewer is very negative at first time. And one of the key issue about the 1 reviewer, they don't agree use the vulnerable terminology. You should use high risk. You don't accept? Our Prevent trial is 4 different, the imaging was used, and the IBUS and the VH most commonly used, and the OCT was used 10%, and the NIRS used 30%. You cannot use the vulnerable terminology. We are mainly focused on plaque, and the reviewer is mainly emphasize the phenotype. So, but we are explaining 1.5 pages to explain why we should use vulnerable terminology. They finally accepted. How do you think about this Prevent trial? Do you think about vulnerable terminology is good for our Prevent trial? We should think about changing terminology?
Yeah, we've discussed that a lot in our group, and we're using the term biologically active plaques. So biologically active versus inactive plaques is the term we're using.
So I don't have a problem with the term vulnerable. And I don't think it necessarily has to mean that you have a death from it. So, a lot of what we do is to reduce repeat revascularization. That's an important endpoint per patient. A lot of it is reduced to MI, and a lot of it is to reduce death. Nothing in interventional cardiology has huge absolute risk reductions anymore. So why is a 1% reduction in myocardial infarction any more or less important than a 1% risk reduction in breast cancer, right? I think it's all how we put these contexts into perspective, but then also how much effort it is to detect this, and then put it into a much more global context of health economics. But in and of itself, detecting patients, whether it's 1% or 2% who have a heart attack, is very, very important.
Any comment?
Yeah, I think now the patient like to receive the personalized treatment, not randomized, not evidence. So I think the imaging message that for the patient prevent plaque rupture, that's a very useful information for the patient, I think.
Okay, I have a question to Dr. Chang, and thank you for your insightful talk. And how can we actually quantify perivascular inflammation after taking CT scan, and how can we apply those numbers to your clinical practice?
Nothing in clinical practice, but there are 2 groups, maybe more. So initially, the first publication was in Lancet by Oxford group, and we've been collaborating with Dr. Damini Day and Cedars-Sinai. So they have a program. What PCAT indicates is in the beginning of inflammation, there's a crosstalk between perivascular adipose tissue and the vessel wall, and cytokines move back and forth, will change the density and morphology of adipocyte. So with continuous inflammation, density will drop, the size of adipose site will become smaller. That creates gradient. That's what you measure. It's an objective computer-generated number.
So Akiko, how do you think about the, in prospect trial is mainly focused on the plaque, the volume rather than phenotype? Do you agree vulnerable plaque is prospective? Is terminology issue? Is a vulnerable plaque or high-risk plaque?
I think I'm okay to call the high-risk plaque, no problem. And I know the prospect of having only 6 MI, I know. But I think ultimately what we really want to know is what is a kind of high-risk plaque, and then ultimately we would like to prevent the primary prevention cohort causing the MI in the outside of the hospital. That's, I think, the real goal. And I think the phenotype should be consistent. What we see in the progression of the plaque and what causing the sudden death should be all like the ruptured plaque, and just difference is the amount of the thrombus. So I think what we learned in the past 20 years is really what we can improve in the future, really primary prevention, sudden death decrease. That's, I think, our goal.
You know, something else that we learned very importantly over the last 20 years from when IK's, Wall Street Journal, is about the plaque biology, right? So when Akiko and I studied Prospect, I was a complete non-believer in this. Then I'm like, this is nonsense. Then I reviewed every single angiogram in Prospect, and you see this pattern, which IK was describing, of rapid lesion progression. The lesions are stable for years. The orbita patient, right? Angiogram looks horrible. They stay exactly the same. They come back 5 years later, it looks exactly the same. But when they're biologically active, they have these sudden bursts. And what that does is it gives us the opportunity to understand why that happens, which is probably intraplaque hemorrhage, right? Intraplaque hemorrhage creates a swelling in the artery, because it creates a sudden stenosis, then we get a healing event. So it also provides us a target for medical therapy where we might be able to approach and reduce vulnerability outside of just lipid by trying to, thicken the cap, which takes months or years, et cetera.
So, okay, go ahead.
If I can ask Dr. Mehta, so you use biologically active plaque. So plaque erosion is not necessarily biologically very active. It's totally different entity with different underlying mechanism. Sure, maybe, maybe not. So if you use the terminology, that will exclude 40%?
No, I agree with you completely. I mean, these are different biologies. I'm not saying that. I think the point is that the overall terminology of a vulnerable plaque doesn't necessarily have to lead to a hard endpoint of death.
There is a question from the audience.
Yeah, I have two questions. First is the vulnerable plaque. So according to the Prevent trial, it's mainly focused on the TICVA, but how about the erosion? So because as Dr. Akiko mentioned, so if we identify the erodic or like a correspondence with the endothelial irregularity, should we treat it or not based on the Prevent trial? The second question is also for Dr. Akiko, is that, so how do you foresee the use of the autofluorescence OCT instead of like other OCT plus a nurse? Thank you.
If I can answer. So the exact mechanism of plaque erosion is unknown. For the past 10 years, we've been working closely with Peter Libby, basic scientist from Brigham. He believes sudden change in local flow pattern, computational flow dynamics, will activate toll-like receptor 2, which will damage and denudate endothelium. Then you have to think, what will change local flow dynamics suddenly? This is, endothelial shear stress gradient, oscillatory shear index, they are all related to morphologic narrowing, nothing else. So when do you see sudden change in local structure? Yes, intraplaque hemorrhage, which is actually very rare. Other than few case report, I'm not aware of any other systemic studies. Or spasm, but you have to understand plaque, the spasm is not the etiology of plaque erosion. As we said multiple times, plaque erosion is a totally different entity with different underlying mechanism. Plaque spasm may contribute, but is not the etiology of plaque erosion. We had some paper we were asked to review. We tried to teach the authors that's not the same entity. He didn't get it. We still let them publish.
Yeah, I think that's very important. I totally agree. We really don't know well in terms of what is the high-risk plaque to predict the plaque erosion. To answer your second question, I think because we are so poor positive predictive value, including the intravascular imaging, even TEC4, so I think we need more, especially like inflammation information. So that's promising because looking for the intraplaque hemorrhage and other factor. So, but not absolute. So, but still additional different aspect of the plaque morphology. So that's, I think, important in the near future.
Okay, so I think as the time goes on, and we're gonna move to second part. It's about the treatment session of a vulnerable plaque. As I remind you, at the time of a prevent trial, is presentation at the ACC. At the time on the Twitter, it's like a revenge of the PCI or overcoming ischemia trial hurdle, and we're gonna talking from the many important, the panel. And the first talk is about Shamir Mehta is a PI of a complete trial and identifying vulnerable plaque. It's a predict cardiovascular medicine in ACS and complete 2 OCT study.
Well, thanks very much. I enjoyed the discussion. So I'm going to focus my talk today on non-culprit lesions, so ACS non-culprit lesions, and try to understand the plaque morphology of these non-culprit lesions in relation to the physiology, angiography, and image-guided revascularization. So the stable, on the extreme side, we have stable CAD, can result in chronic coronary syndromes, or patients may be completely asymptomatic. These are mostly fibrocalcific plaques. They have thick fibrous cap, a small lipid core, and they're at very low risk of plaque rupture. They do plaque rupture, they can transform, but in general, these plaques are stable. And a physiology-guided strategy is useful in that situation because it can identify lesions that are causing angina, you can target them with PCI, and you can make the patient feel better. And then at the very other end of the spectrum of coronary disease, so at the extreme right side of this slide, we have acute plaque rupture with thrombotic occlusion resulting in STEMI, which is a life-threatening condition. Same disease, just 2 very different parts of the spectrum. And in this type of plaque, it's a very different type of plaque. This is a thin fibrous, this plaque has a thin fibrous cap, it has a necrotic lipid core, it's infiltrated with inflammatory cells, and it's what we talked about earlier. This is a biologically active plaque that ruptures and creates thrombosis. In this particular situation, we don't do physiology. We treat that lesion as a medical emergency. We use an angiography-guided strategy, and we put a stent in. Physiology is not helpful in that situation. I just want to show you the contrasts in coronary disease. When we talk only about a physiology-guided strategy, we need to put it into context. What context and what clinical scenario are you talking about? And then we have the non-culprit lesions. Where do they lie? And this has really been the controversy over the last decade or so. What is the pathophysiology of these non-culprit lesions? Do they resemble more of the stable CAD type of plaque, or are they more akin to the STEMI culprit lesion that just had plaque rupture? And that's been the whole question, and that will then help us decide whether we should be using a physiology-guided strategy, an angiography-guided strategy, or even an image-guided strategy when we target an ACS non-culprit lesion. So we know that if you just go ahead and do PCI on all lesions that are visually more than 70%, so this is an angiography-guided strategy, there's a benefit. We showed that in the complete trial. But what we also showed is that when you look at stenosis severity of the non-culprit lesion, almost all of the benefit, at least when we're looking at the first co-primary outcome, so this is not revascularization, this is just cardiovascular death or new MI. So this essentially is plaque rupture. When you look at that hard outcome, all of the benefit was in the tighter non-culprit lesions. So QCA stenosis of more than 60%. The QCA stenosis was less than 60%. And remember, a QCA stenosis of 60%, those of you that don't know about QCA, it's roughly equivalent to a visual stenosis, very roughly, of about 80%. So it's a tight lesion. A QCA 60 is a tight lesion. Versus QCA less than 60, you'll see the Kaplan-Meier curves are completely superimposable with each other. This is a review of about 6,000 coronary angiograms. This is not a small sample size. It's a very, very large sample size, and the interaction p-value here is significant. So the question is, what is going on here, and why is this happening? Is this real, first of all, or is this just a subgroup analysis where we're being led astray? So we had some mechanistic insights from the trial. We did 3-vessel OCT imaging in a small subset of patients to try to understand what are these non-culprit lesions, what is the plaque physiology all about. And so what we found, and similar to the studies that we had that were shown earlier,
that if we look at all of these non-culprit lesions, about half of them are unstable plaques. Or if you look at a patient level, about half of the patients with obstructive non-culprit lesions have an unstable or biologically active plaque, i.e. a TICFA as defined on OCT, 47.3% to be precise. Very similar to the rate of TICFA that they have seen on non-invasive imaging, as well as other types of invasive imaging in this patient population. Now, if we look at the lesions and we categorize them as to whether they are obstructive, so they're more than 70%, and as to whether or not there's a TICFA there or not, what we find is that in the obstructive lesions, so we're only looking at tight lesions now, and we compare the TICFA to the non-TICFA, obstructive TICFA lesions have significantly more lipid. There's more features of plaque vulnerability compared with non-obstructive TICFA lesions. This is really important, and this may explain why there's a benefit of complete revascularization, at least with an angiography-guided strategy. Obstructive lesions are much more likely to harbor a TICFA than a non-obstructive lesion is. Even though the non-obstructive lesions are much more commonly found, the probability that a tighter lesion is a TICFA is much higher than in a lesion that is less severe. And that was shown in our study and in many other studies. This has been shown in non-invasive imaging studies, and this is an OCT study that is essentially showing exactly the same thing, that if you have a tight non-culprit lesion, it's much more likely to represent an unstable plaque than if it is a less severe lesion. And that may be one of the reasons why we saw a benefit. But remember, the study is even more complicated. The whole field is even more complicated than that, because when we do an OCT image, it is a snapshot in time, and those plaques have a chance to remodel and change over time. So that if you have a TICFA, 1 year later, if you're on high-dose statin therapy or a PCSK9 inhibitor, that may no longer be a TICFA. That may not result in a clinical event. So that these plaques are remodeling constantly and they're changing. So that's another parameter that we have to consider when we're looking at these prospective studies correlating these OCT findings with outcome events. Nevertheless, when you do look at a snapshot in time, there seems to be a correlation with clinical events, at least using IVUS, virtual histology, in Prospect 2, and then the lipid-rich study, lipid-rich plaque study showing exactly the same thing, that about half of the events that occur in these patients with multi-vessel disease are occurring from the non-culprit lesion, and the other half are occurring from the culprit lesion itself. So they're not quiescent lesions. So perhaps that one snapshot in time, when we do look at those lesions, is important in predicting events. We don't know for sure yet, but that's certainly what the data is suggesting. Now, in the Complete 2 study, we want to really study this and try to understand it in a lot more detail than what we currently understand. So you know that the original randomization in the trial is physiology versus angiography, but we have a large OCT imaging study. So the type of study that I showed you with IVUS, virtual histology, NIRS, IVUS, has never been done with OCT imaging. We have no idea what correlates the findings that we see in the non-culprit lesions with clinical outcomes. And that's the primary objective of the Complete 2 OCT study. It's to determine in patients with STEMI or non-STEMI and multi-vessel disease whether vulnerable plaque, as identified on OCT imaging, predicts major cardiovascular events. It's a large-scale prospective study. We're looking at 1,510 patients, and we're going to be correlating this not only with heart outcomes, but also looking at rapid plaque progression that we talked about earlier, and clinical outcomes. And this will all be integrated. And by the way, when this is done, we'll be using Ziad's algorithm of MLD max to guide the PCI, because we think it's safer if you're using imaging to guide your PCI. We know at the very least that it reduces stent thrombosis, which is one of the most important things for the interventional cardiologist. And these are just the prior studies that have been done with OCT. They've been good studies, but most of these trials have been relatively modest in size, and they have been mostly retrospective studies. We need a good prospective study in order to fill some of the gaps that we have so that we can ultimately get to our ultimate goal, which is going to be an image-guided PCI approach, where we look at a lesion, we identify a high-risk plaque, and we can go ahead and perform PCI. But likely we'll get to that stage Only when we have enough data, such as data from Complete-2 and all of the other data that we have with OCT imaging, that will be put into an AI-based analysis, and that likely will be the future, I think, of PCI and image-based PCI. Thank you.
Thank you. So we're going to move to the debate about preventive PCI's conspart and vulnerable plaque stabilization with OMT and Professor Kubo from Japan.
Thank you. So intravascular imaging is definitely useful to understand the plaque stabilization. This is IRIS. So IRIS clearly demonstrates decrease in plaque volume and in plaque volume by OMT with statin. This is OCT and NIRS. So OCT, it shows an increase in fibrous cap thickness by lipid-lowering therapy with PCSK9 inhibitor. And on NIRS, it clearly demonstrates the decrease in the lipid co-binding index by lipid-lowering therapy with PCSK9 inhibitor. So previously, we performed the EasyFit OCT trial comparing high-dose statin versus low-dose statin using a serial OCT imaging at baseline and 12 months follow-up. And this study demonstrated high-dose statin provided a greater increase in fibrous cap thickness in coronary plaques compared with low-dose statin. Also, this study demonstrated the % change in the serum levels of LDL cholesterol level, LDL cholesterol, high sensitive CRP, and MMP9 was negatively correlated with the % change in the fibrous cap thickness. And we also performed the ESCOT OCT trial comparing early statin versus the late statin. The target was HCS patient. As early statin group, their statin was administered immediately after primary PCI. And the late statin group, we administered the statin at 3 weeks follow-up. And we performed the OCT baseline 3 weeks and 6 months. This is an example of the early statin group. OCT clearly shows the increase of the fibrous cap thickness at 3 weeks follow-up. On the other hand, this is the late statin group. The OCT clearly visualized the fibrous cap disruption at 3 weeks follow-up compared to their baseline. So this is the data. The fibrous cap change in late statin group. The fibrous cap thickness decreased at 3 weeks compared to the baseline. And the early statin group, as fibrous cap thickness increased at 3 weeks compared to the baseline. So early statin administration is very important to plaque stabilization in SS patients. So recently, we can use the PCSK9 inhibitor. This is a Horizons trial. The PCSK9 inhibitor Evelyn resulted in the greater increase in the minimum fibrous cap thickness. And this is a Pacman AMI study. Pacman AMI study used NIRS and OCT. And this study demonstrated the PCSK9 inhibitor alirocumab significantly reduced arterial volume and maxillary CVI4 compared with placebo. And also, Pacman AMI study investigated about the macrophages infiltration. So this study demonstrated the PCSK9 inhibitor alirocumab significantly reduced the mean angular extension of macrophages compared with placebo. So this is a summary of the recent clinical trials showing the effect of lipid-lowering therapy on fibrous cap thickness and plaque volume. The OCT trials have shown a direct association between achieved LDL cholesterol levels and change in fibrous cap thickness. And also, IVUS trials have shown that significant reduction in LDL cholesterol levels achieved by more intensive lipid-lowering regimens lead to greater plaque regression. So, conclusion. Based on the imaging study, OMT is very, very effective to stabilize the plaque. And the serial intravascular imaging allows us the observation of vulnerable plaque stabilization characterized by decreased arterial volume, decreased lipid core, increased fibrous cap thickness, and decreased macrophages infiltration. Thank you for your attention.
Thank you. So, and the preventive PCI and the post part and the SJ part and the preventive trial, prevent trial.
Thank you. As we presented our data in the last ACC meeting, preventive PCI versus medical therapy alone for treatment of a vulnerable atherosclerotic coronary plaque. Look at the background. The intracoronary imaging defined vulnerable plaque has more tendency to increase major adverse cardiac event. Optimal medical therapy is the standard approach to stabilize the plaque vulnerability. So, safety and effectiveness of a focal preventive PCI actually are unknown, and so we want to do whether to assess the whether focal preventive PCI of non-flow limiting imaging-defined vulnerable plaque improved clinical outcomes compared with the optimal medical therapy alone. So we have conducted our study, our family, and Greg Stone actually helped us. 15 sites in the Asian Pacific area actively involved this one. Okay, if you look at the trial design, more than 50% angiographic stenosis, significant stenosis, and negative FFR, and image guided, and out of 4, 2 out of 4 following condition. So we defined the vulnerable plaque, in imaging defined the vulnerable plaque, and minimal luminator less than 4, plaque burden more than 70%, syncape fibroadenoma by OCT or RFIs, and the repeat-rich plaque, LCBI index more than 315. We randomized with the preventive PCI and optimal medical treatment. Primary endpoint, the target vessel failure at 2 years, more than 18 years. Just I mentioned about, significant stenosis, negative FFR, imaging defined the vulnerable plaque, 2 conditions out of 4 factors, eligible PCI. We started with observed BBS and everolimus loading stent, reference vessel diameter more than 2.75, less than 4, lesion length less than 40 millimeters. Major exclusion, preferred treatment bypass surgery, and patient with a 3 or more target lesion, 2 patient with 2 target lesion in same coronary artery, heavily calcified, bifurcation lesion, contraindication, planned dual antiplatelet therapy. We excluded. If you look at the procedures, during the initial recruitment period of our study, we used BBS. And following the withdrawal of BBS, we used the Giants, were used for the default device of PCI. All the cases we use the intravascular imaging, patient is with the dual antiplatelet therapy at least 6 or 12 months after PCI. Clinical follow-up was done 6 months, 2 years, and every year. This is a typical example. Look at that. Diameter stenosis, 70%, more than 50%. Negative FFR, 0.83. If you look at the imaging concern, gray obvious, minimal luminator less than 4 millimeter square, plaque burden 79%, syncape fibroadenoma defined by RF-IBUS, and maximum LCBI 573 is included our study, and we deployed the BBS like this. So Primary endpoint target vessel failure, a composite of deaths from cardiac cause, target vessel myocardial infarction, ischemic-driven TBR, hospitalization of unstable or progressive angina at 2 years after randomization. As a secondary endpoint, individual component of a primary composite outcome, patient-oriented composite of all-cause deaths, all myocardial infarction, or any repeated revascularization, procedural safety outcomes, stroke, breathing concern. And power calculations, we gathered 1,600 patients for our study. Look at this, very important issue. We screened 5,000, more than 600 patients. So among them, 63% angiographic stenosis, significant stenosis, 63% of patients had negative FFR. And among them, almost 45% of a lesion subset, satisfied the imaging criteria for bolus plaque. It's quite same with the Dr. Mehta's, complete study. Even in the stable angina, we randomized the prevent PCI and optimal medical treatment. Some, crossover from in each arm. And finally, we do 100% intention to treat analysis here. Baseline characteristics, 64, mean age, and diabetics, 30%. Quite similar between the two groups. Stable angina, 83%. Unstable, 13%. Non-STS elevation of my very small, 3%. Qualifying criteria for target lesion, minimal lumen area less than 4 millimeter square is 97%, plaque burden more than 70%, 97%, high repeat rich plaque 28%, and syncap fibroarthropathy 7%, LAD mainly 50%, circumflex right coronary artery. Diameter stenosis is mean diameter stenosis 56%, very low grade of stenosis here. 1.3 reference vessel diameter 3.1, lesion length 20, 3.6. Ibis measurement is almost same. Minimal lumen area less than 4 millimeter square, 2.8 millimeter. Plaque burden 76%. Plaque level maximal LCBI index more than 315, 41%. Syncap fibroarthropathy 13%. By OCT definition is 18%. High-risk plaque features more than two, combined two reasons, so 89% here. Trickleton stent, 67%, PBS 33%, number of stent median number 1, scaffold diameter. Look at the 3.5. The meaning is a relatively big vessel. We used a big stent. Total stent length less than 23. Not too long lesion subset is almost all cases with the imaging guide. Patient without non-target vessel, actually the preventive PCI-related acute adverse event not much, very small number of acute scaffold thrombosis. So only one case, distal dissection, side ventricular occlusion, very safe procedure. So as a primary outcome, composite outcome, target vessel failure at 2 years, optimal medical treatment 3.4%, and preventive PCI 0.4%. A very small number of events, and the efficacy concern is sustained 7 years follow-up, 6.5%, and preventive PCI 9.4%. Optimal medical treatment is clearly statistically different between the two. Patient-oriented composite outcome, so that's from any cause, any MI, any repeated revascularization, actually statistically difference between the two. Prevent PCI clearly better than optimal medical treatment. If you look at the individual component of a primary composite outcome here, deaths from cardiac deaths, actually no difference. Target vessel-related MI, no difference. So main difference is ischemic-driven target vessel revascularization and hospitalization for unstable or progressive angina. If you look at the secondary endpoint, Any deaths, all deaths, no difference. Non-target vessel microinfarction, no difference. Non-target vessel revascularization, no difference. Stent thrombosis, scapula thrombosis, no difference at all. Stroke, bleeding event, no difference at all. Right. If you look at the subgroup analysis of primary outcomes, at 2 years, actually, no difference in significant interaction between subgroup analysis here. However, look at this. Primary outcome, 7 years follow-up, interestingly, PCI of a non-target vessel for those cases is better. A preventive PCI, median diameter is a little bit significant, more than 55%, and preventive PCI modality concern, drug-eluting stent, is clearly better than the bioobservable scaffold. Right, studies limitation, open label, introducing risk of a placebo effect, observed the rate of primary outcome was substantially too low. The selection of imaging modality to assess the plaque vulnerability was left to operator discretion. 9% in preventive PCI, 1% OMT group. Crossover, the study did not collect data to examine the cost effectiveness concern. That use a little bit greater in the preventive PCI group. So, out of summary, PREVENT trial is the first large-scale randomized controlled study comparing preventive PCI versus OMT alone to treatment of non-flow limiting negative FFR, imaging-defined vulnerable plaque. PREVENT trial clearly reduced composite risk of death, cardiac death, target vessel MI ischemic-driven TBR, and hospitalization. Preventive PCI also reduced the composite patient-oriented outcomes, all deaths, all MI, all any repeated revascularization. Benefit was sustained through the 7-year follow-up period. Conclusion. Preventive PCI plus optimal medical treatment resulted in a low incidence of a major adverse cardiac event compared with the optimal medical therapy alone in patients with non-flow limiting vulnerable plaques. That's our key findings might provide an overall insight on the role of preventive PCI for those particular high-risk vulnerable plaque patients. Thank you.
Thank you. So we have enough discussion time. So after release time, the PREVENT trial, Greg Stone's post the poll at the Twitter after release of the PREVENT trial. How do you treat if you find the vulnerable plaque and look for them and the medication 17%? I will do preventive PCI 18%, and the not treat don't believe 14%, and the need second trial is 51%. So I would like to raise the point in this stage. You find the imaging detective vulnerable plaque is how do you treat? OMT? Raise your hand. Is it prevent PCI? Raise your hand. No answer. Is it okay?
Well,
we can discuss.
I think it depends. Because if you're doing a PCI anyway, so the non-culprit vessel, which actually the interaction shows there may be some benefit, then I think it makes more sense. So how do you apply this information practically? You're doing a PCI in the LAD, you've done a pullback, you've already paid for the catheter, and now you see a vulnerable plaque, intermediate lesion in the proximal LAD or in the non-culprit circumflex. That's the question, right? And I think in that situation, what you can say is the safety of doing a prophylactic PCI is very, very low. So the additional cost is simply the cost of the stent.
Any additional opinion for preventive PCI? So
I have a question to Dr. Doug Park. Congratulations on your successful study. And in your PREVENT trial, optimal medical therapy were similar between the two groups during 7-year follow-up, right?
Yes.
And
right.
Also, what about the lipid profiles and inflammatory markers? Were they similar during?
So, and at the initial time, is LDL level is 87. During follow-up, is quite comparable, 66 milligram per deciliter in both groups. That means it's quite controlled well, less than 70%, and even stable angina at 80%, ACS 20%, LDL, the mean level is a 66, is quite controlled well, yeah. So, and the Kubo,
If I can ask.
Yeah, I was just interested that most of the outcome was revascular, like was ischemia-driven revascularization. So that suggests there was rapid plaque progression in the patients that did not receive PCI. Do you have an angiographic core lab? Like, are you able to correlate it with other measures other than ischemia? Like, presumably most patients had a wire put down, they had ischemia detected, and then they had a revascularization procedure done. But is there angiographic evidence or any type of imaging evidence to show us that? Or?
So, and in the PREVENT trial, in the initial enrollment criteria, we have the visual estimation is diameter stenosis of the 50, more than 50. We are, is the target enrollment criteria. Is after ending the procedure, our central core rep in the QCL less than 50. That means our visual estimation more than 50. And if you're gonna do core rep QCA, there was just a 42 and 43, and the QCA measurement is much, much lower. That absolutely means intermediate coronary stenosis, yes.
At baseline?
Yeah.
But what about in the patients that follow up, when they had like ischemia-driven revasc? Do you have?
Yeah, so ischemic-driven revascularization mainly on the we didn't do and the routine follow-up angio anymore, and the absolutely symptom-driven. Is a patient complaint, unstable angina, any symptom, we do not allow any systematic coronary angiography follow.
Dr. Park, please.
All right. I just, Dr. Mehta's presentation, so you mentioned about the acute coronary syndrome non-culprit region subset. You have some question about the angio-guided and FFR-guided, right? Macro infarction acceleration is angio-guided. However, still, even in the acute coronary syndrome, so you mentioned about the non-culprit lesions. Our practice concern is based on our practice concern. FFR first. If FFR positive, treat them, no doubt about it, right? And then, if functionally negative FFR, you mentioned about the 50% is syncytial fibroadenoma, and you have to define how much, high risk bulbar plaque, how many conditions would be combined for that, and FFR first, no doubt about that one. And then, if negative FFR, you have to define, just like our study progress, and they define the bulbar plaque, and treat or not treat, we need a large size, really, randomized study about it. Even in the acute coronary syndrome, we are going to start, PREVENT-2 trial in terms of, even in any situation, stable angina, acute coronary syndrome, if we want to do, non-culprit 3-vessel imaging study, and then we want to do the random study for that. And so I think it's just, provoking hypothesis, and maybe as the next step, we need a big, randomized study.
Yeah. If I can ask Dr. Park, what's the next?
Okay. Go ahead.
Okay, go ahead.
Dr. Park. So what's the next? Next plan.
There is a
Not yet. However, we just, our meeting in ACC, we're going to name of our next study, PREVENT-2 study. And so we're going to include a lot of, CT guided, just in the care, we do invasive imaging or angiographic, sometimes some culprit treat and non-culprit multivessel disease. Why not? You want to do imaging first. And then we want to do just like this random study.
Yeah, congratulations for the great study. I don't want to be a so skeptical person, but I have to say this. In preventive PCI arm, acute complication rate was 0.6%. 2-year event rate, 0.4%. Actually, the acute complication rate was higher than 2-year event rate. And also, preventive PCI arm, much higher initial medical cost. in modern medicine, we don't do surgery for the metastatic carcinoma. I'm having some confusion about, as Professor Jang said, this is pan-vascular process, and medical treatment will change the plaque characteristics in substantial proportion of the plaque. Why do we need local stent implantation for the dynamic process? So I don't know how to justify this strategy in my daily routine practice.
I think that is a key critics from our reviewer, is New England Journal of Medicine and the Lancet. You know. So, okay, go ahead. Yeah.
Well, when we started our study, particularly, so we assuming the MACE rate as more than 10% something. However, we don't have any data at that time. And then look at that, just as I think about it, not too much significant stenosis, even in the more than 70% plaque burden is a not pretty big one. And so if you use deploy the stent for the normal looking artery, the result would be good. If we have some reasoning, why not? We're going to do that for the political plaque concern. So the MACE rate is very low. The reason why we deploy the stent, regulating stent for the very insignificant stenosis and normal looking artery, big artery, 3.5 stent, deployed over there. The result must be good. However, you're going to make a difference. Anyway, just if we get a more large number of patients, there are maybe some another difference in the individual component, in cardiac death. Maybe there are some trend, Dr. Bach, you can say that even cardiac death, the hard endpoint, there's some difference there. So however, we cannot, say that.
Okay, Carlos?
Yeah, I think what is emerging from this data is that when you look at complete, and you see diameter stenosis being the driving factor for patient selection, you see the interaction tested in Prevent showing the same thing, high diameter stenosis benefiting more from PCI. And you see the link with FFR and thin calf hypertrophy. And we have recently also described that the presence of thin calf hypertrophy relates to the focality of the disease on the pullback. I think we're kind of putting everything in the same bag now. Now, I want the opinion of the panel on the fact that you can have a high plaque burden, you can have a plaque composition that is adverse lipidic, let's say, but what breaks a plaque is the force that is applied to the translational pressure gradient. That's the event that breaks the plaque. When that force exceeds the resistance of the plaque is when plaque rupture occurs. And I think we have not yet factored in the physiological component into the vulnerable plaque equation, which is being done from the CT space, but in the invasive part, that is a bit less used. So I would like to have your opinion on how can we incorporate this in the future studies.
Well, we're going to have a lot of that data in Complete 2 for the deferred lesions, and we'll have physiology and we'll have imaging, and we'll be following them for 5 years. So we should talk.
But maybe one place where we'll get there is when we have imaging-based physiology, right? That's the marriage that we've been sort of waiting for. So we'll be able to determine the focality based on the pullback from your OCT FFR, for example. And so we'll have the benefits of both helping us decide which of those two is actually more important, or maybe they both are.
Okay, Kubo, and any comment? You are still the strong believer of OMT is okay?
But I'm supporter for the PCI, preventive PCI, prophylactic PCI for the vulnerable plaques. So I have a question, or I would like to give me advice. So in our daily clinical practice, I'm wondering what should we do in a specific cases in patient with multiple coronary atherosclerotic risk patient and proximal LAD and bifurcation along the diffuse disease. It may be a high risk for the periprocedure MI. So how should we do in those cases based on the Prevent trial?
Dr. Plaque, I have one question. I think from Prevent trial, take-home message is the optimal medical therapy, strict optimal medical therapy is important. OMT means the drug adherence, stop smoking, and then the exercise and diet. And I think my experience, put the stent After I put the stent, patient behavior, big change, move to big change. But keeping the OMT, not change so much. So I asked to you, in your trial, 2 arms, smoking, exercise, diet, and drug addiction. How much different? How do you think?
Yeah, it's a medical therapy. It's both two groups is quite comparable. It's no difference at all in the randomized trial group. As you mentioned, Dr. Kubo, one of the key issues of the PREVENT trial is a result, is provocative, is many review, many physicians think about the PREVENT trial, the one of a seminal trial in the history of the PCI. So next, how do you apply in our real practice? How do you define? How do you treat? As you mentioned, in our catheter, we found the intermediate region is we treat the LAD corporate region, RCA, SOC is the intermediate region. We're gonna do everything FFR, we're gonna do everything imaging. That would be the next step. That is not easy to answer by PREVENT trial. We do more cumulative evidence like a complete trial, more evidence, and the ongoing trial is remaining 2 or 3, and a few years later we have more definite answer for that.
Dr. Park, for your next study, I understand your final LDL was in the 60s, right? I know it missed the guideline, but in real practice, at least in Boston, my target LDL is 30s. Not only mine, many of my colleagues. So I just want you to consider when you design next phase.
Yes, this trial is a PREVENT trial. It's almost done. It's over the last 10 years. Yeah, at that time it's a LDL recommendation. We use 60-70% high dose statin or moderate dose statin plus ezetimibe as a recommendation. Is the LDL in Korean guideline less than 70. It's okay. Recent updated is 55. Is last year. We would like follow the contemporary the medication guideline. In the future would be some change. Okay, I think time is already done, and this is a very nice discussion time. And could you summarize in this session?
Let me conclude this session with we had a highly animated discussion. I think what became obvious is that if a patient has a thin cap fibroateroma, we are today able to detect it, and we also have treatment options. So I would be a little bit careful with, making treatment decision dependent on whether I need an additional guide catheter for the right coronary artery or not. I would factor in the patient. Why not ask our patients? We have now data, we have knowledge, we can educate the patients, we can assess the risk, and as you clearly said, we can factor the patient in. So I guess for me, the conclusion of the session is we can find thin cap fibroateroma, and we can, in an educated way, make treatments proposition to our patient. Thank you very much.
Thank you.